we have a very important topic here, and a topic that kind of drives me crazy as a therapist, which is getting an accurate testosterone level for my patients, because so often people come to me seeking therapy, sex therapy. How do you get an accurate testosterone reading, and when do you go? When should you go?
Yeah, great. So, listen, this is one of the biggest topics, and the other thing that is tough is interpreting what the results mean.
Before we start, a small disclaimer. The Sex Doctors podcast is not a substitute for medical or psychological advice.
Yes, that's right.
Yeah. So, and it's, if I may, I wouldn't say that whether or not it's an accurate test. It's about, which is the most useful test or tests.
Okay.
Right? So they're all accurate to some extent, but, what is it that we're measuring that makes the difference?
Okay.
Okay?
What is it that we're...
So listen, there's men and women are, as it turns out, actually kind of similar around this in the testing. Mm-hmm. Some people might argue, but so first I just got to explain that when we're measuring testosterone, we're looking at how much is in the body, whether somebody has low levels that might explain their symptoms, right?
Yeah.
So you said, when should you test? Who should be tested? And usually for a man, the reason to test is they have symptoms that are suggestive of low testosterone. What are those? So they can be sexual.
Mm-hmm.
The classic is low sex drive,
mm-hmm.
but also guys can have trouble with erections.
Mm-hmm.
They can have trouble maintaining their erections.
Mm-hmm.
The orgasm can feel less intense.
Mm-hmm.
They may have more difficulty achieving an orgasm at all. Those are the sexual symptoms. The non-sexual symptoms tend to be things like the guys are tired without it making any sense to them, like they're tired out of proportion to whatever it is that they do. We're all tired. Like everybody these days is tired all the time.
Yeah.
But this is a kind of fatigue or that doesn't make sense to them. It's just beyond the pale.
And people often think they go to depression, right? And my colleagues always go there. Like, which I completely support, but let's not go there until we know that there's if there's a hormonal imbalance, that's what needs to be dealt with first.
Yeah.
And then we deal with what's left over after that's next week. So
I got to tell you, years ago, I had a patient who was mid-60s, I would say, was a psychiatrist. And he'd been self-treating himself with 3 antidepressants. His testosterone level was low. He went on testosterone. He got off all his antidepressants. And he said to me afterwards, he says, it wasn't depression, it was testosterone. And he says to me, I've been treating other men with what he called, his term was middle-aged male malaise, like this. And he says, I could have to wonder how many of them have low testosterone.
So here's the thing. So what we do in my profession in general, in mental health, is we treat guys with medicine that makes their sexual symptoms worse.
Right.
So,
right. Absolutely. Antidepressants are awful for sexual function, Yeah. Right. So they start off with that, and God forbid it's not depression.
Right. So they treat a hormonal imbalance with an antidepressant, and they make the sexual situation worse. It's very frustrating.
And just to be clear, so we hate to say that testosterone is the cause of a major depression. Like if somebody is thinking helpless, hopeless, suicidal.
Yeah, no.
We don't want to treat them or pretend that testosterone is good therapy for them. But
see, this is why we call you a psychourologist, because that's true.
Very kind of you. Very kind of you.
Yeah.
Yeah. So, but there is now level 1 evidence, highest quality evidence from multiple randomized controlled trials that testosterone impacts mood.
Yeah.
Clinicians have seen
women too. This isn't just men we're talking here.
Women too.
Yeah.
But the everybody always, in medicine, they're always saying, well, show me your large randomized controlled trial. And for a long time we didn't have that, but it was obvious if you treated men, you saw their mood improve.
Yeah.
One of the very few first patients I ever treated back in the late 1980s, where I was just trying to figure out, does this thing work for anybody?
Mm-hmm.
I said to the guy, what do you notice? And I'd seen him for sexual symptoms, and those got better. But what he said blew me away, and I've heard variations on this forever. He said, Doctor, I now wake up in the morning, I sit on my side of my bed, I swing my legs over, and I am optimistic about my day. I haven't felt that way in years and years, he said. And there's no question that testosterone can help with mood.
Yeah.
Yeah.
So important. I mean, life is challenging. Like we need to be at our best to be able to handle all of that out there. Right.
So in men, just sticking to men for a second, who do we treat or who do we even test for because we're thinking about treating and we're wondering if testosterone is the issue? Is I talked to you about sexual symptoms. They're sort of like the psychological symptoms of more sadness, more blue, feeling grayed out, like blah, like loss of sense of excitement, optimism, feeling less energetic, less pep, less motivation to do anything. Some people will say that they feel like they're in a brain fog. You know, they just feel a little bit cloudy. They have trouble. I don't want to get into trouble around name finding or word finding, because that's so common as men get older. It's not always a testosterone. But you put some of those symptoms all together and it starts telling a story. And then there's a third category, which is what we call objective signs, things that you can measure, right? So bone density gets decreased with testosterone. Some people are getting their bone density checked. Muscle mass goes down, fat mass goes up, waist circumference goes up. People say, I'm going to the gym, I can't gain in how much weight there's sort of a regular routine that men have when they work out. It's not like men work out, most men, like on a regular schedule for their whole lives for years. It's episodic, right? Especially after New Year's Day, they've got their New Year's resolutions, they go to the gym for a while. And men are used to being able to start off, if they haven't been doing this for a while, with a certain number of, let's say, push-ups or certain weights with, barbells. And they know that if they keep after it, they're going to be able to do more and more over the course of days to weeks. And a lot of the men now are very savvy about this. And because of the weights, we know what the weights are. They can quantify this. And they say, I can't progress the way that I'm used to progressing my whole life.
Right.
And often that's related to testosterone. So that's who it is.
Okay. So now we've got a guy or a woman and they want to go get their testosterone level measured.
Yeah.
And what happens? They come back with total testosterone in the low normal range.
Yeah.
Total testosterone is not what needs to get measured. Unfortunately, that's what everybody measures, even today.
Yeah. So, and there's still a lot of doctors who think it's the only test.
Yeah.
And that's the right test. So a little backup, I think, important for people to understand. So testosterone circulates in our blood, and blood is what gets it delivered, all the chemicals, to whatever cells needed in the body, whether it's in our brain, whether it's in our toes, right? So it's bloodstream that does it. And in the bloodstream, there are three forms of testosterone. It's the same molecule, but it's attached to different things. So the biggest portion, about 2/3 of it, is attached to this carrier molecule called sex hormone binding globulin.
SHBG.
Yeah, it's too long to say, so we abbreviate SHBG. And the characteristic of that binding is that it's bound so tightly that if testosterone is attached to an SHBG molecule and it's going past a cell that's screaming, hey, I need testosterone, come over here, it can't free itself up because the only way it enters into that cell is by just being testosterone alone. It has to disconnect from that carrier molecule. And that testosterone unattached to anything is the second form, which we call free testosterone. Free doesn't mean you don't have to pay for it. It just means it's unattached, unbound. And then the third way in which it's around is also with a carrier molecule, which is usually the most abundant protein in the blood called albumin. It can attach to other proteins, but mainly albumin. And that characteristic is completely different than SHBG, which is that it comes on and off that protein very easily. And so we consider biologically available testosterone, or sometimes called bioavailable testosterone, the combination of free and the portion attached to albumin.
Oh, okay. So, but that complicates matters. If you need a level, you have to now get it you have to get your albumin too?
No. So in Europe, a lot of people use bioavailable testosterone as a test.
Yeah.
In the United States, it's not used that much, although people do it. And I think that clearly the best test is free testosterone. Yeah. Why? Because free testosterone is the actual component that gets into the cell.
Now, wait, do you just think this, or do others think this too? And, are you backed by research, Dr. Morgentaler?
Yeah. Well, thank you. So listen, so this is a little bit of an evolution. So the reason everybody thought total testosterone was the right thing is because that's how it started. Hormones like testosterone are present in such tiny amounts in the body that it wasn't until the 1970s that they figured out how to detect.
Wow.
And they detected them with antibodies. Antibodies, everybody knows a little bit about antibodies because of COVID.
Yeah.
Right? It's these chemicals that are made by the immune system, usually, and go after very specific, not just chemicals, but parts of chemicals. So you can, we won't go into spike proteins and all those other things, but you can use the antibody to detect minute amounts of stuff. And so in the 1970s came the development of what was called radioimmunoassays, RIAs, and all of a sudden using antibodies, often labeled in that time with a little bit of radioactivity, you could actually go after these tiny molecules. Well, they're not tiny molecules, but tiny amounts of molecules like the hormones like testosterone. So the first thing they knew was testosterone.
Oh,
well,
total.
People weren't sensitive enough. They didn't know enough yet to look at different fractions of testosterone. Now, the part of the problem is that the testosterone that's bound to SHBG isn't useful, but it's measured with total testosterone. And a lot of people...
Useful to the body. It's not useful to the body.
Right. I don't know who it's useful to, but it's not useful to the body.
So why measure? Why do they
measure?
Why measure? Because that's all they knew. That's all they knew. Okay.
So there's a lot of what I call lore, L-O-R-E, like old, I don't want to say fairy tales, but there's things that have been passed on from generation to generation in medicine.
Yeah,
and what was passed on was that total testosterone is the right test. And people didn't like the tests that were developed to measure free testosterone.
Why not?
They thought they weren't accurate or reliable. It's simply not true. But the consensus now is what's acceptable to everybody is what's called a calculated free testosterone. It doesn't matter, but it's a calculation where they measure total testosterone and you get your concentration of SHBG and you can just put it into a computer. They're online now. So listen, I want to tell you a story.
Okay.
To me, it's one of the most amazing stories in all of medicine. I happen to have been involved with it, but it's an incredible thing. And the story is about testosterone and the fear of prostate cancer.
That's a very significant fear. Prostate cancer is the most common cancer among men, is it not?
Absolutely right. Yeah. And the second, maybe now the third most common cause of cancer deaths in men. Like, this is a serious issue. And for about 60 years, the fear that testosterone caused prostate cancer was so great that nobody used it.
Right. People are so understandably afraid of cancer that they get very frightened.
Absolutely right.
Wanting to prevent it. Yeah.
Yeah. So it's an amazing, just amazing story. And I think it's got lessons for all of medicine. And the bottom line is that medicine sort of writ big, right? Writ large, like all of medicine, capital M medicine. And physicians in general and what we learn, what we're taught, what we teach even, can sometimes be crazy wrong.
Yeah. We don't like to think about that, those of us who aren't physicians.
Right.
So, maybe we should delete that.
No, but sometimes they're concepts, like foundational concepts, and they get accepted. And this is true in every area, right? I'm sure you've got this in psychology, where there are ideas that become dominant. Everybody goes along with them. And then at some point, it's like that character from Saturday Night Live, played by Gilda Wren in Nutella, whatever. She goes, never mind. Like, she goes on a rant, and then at the end of her rant, she finds out she misheard something. She says, never mind. And that's kind of where we are with this. So listen, so here's the story. So when I was a resident in training in urology in the mid-1980s, 1984 to 1988, we learned that there was this guy named Charles Huggins who had won the Nobel Prize, the only Nobel Prize won by a urologist for urology. And
Still?
Well,
Just curious.
yeah, still. Well, there was a second guy who got the Nobel Prize, a guy named Forsman, but he didn't do it for anything in urology. He was like he became a urologist, but when he was like a surgery resident, he put a wire in his vein.
Oh, God.
It went all the way up into his heart. He ran over to fluoroscopy or x-ray. They took an x-ray and showed that the wire was in his heart.
Oh,
so that became
God.
the access for all sorts of things we do with interventional cardiology.
He did deserve a Nobel Prize.
Yeah, it was really clever.
Wow.
But he didn't win it for urology. He won it as a resident, but he became a urologist. So there are two urologists who have won Nobel Prizes, but Huggins was the great man in urology. And he showed for the first time that you could take men with metastatic prostate cancer, castrate them, remove their testicles.
So another unfortunate concept here today.
yeah, and
All right.
and
I can do this.
and that the prostate cancer seemed to get better. And what was amazing about that, and the reason he became the great man in urology, is that we still use this as the mainstay of treatment for advanced prostate cancer today. We don't usually take off the testicles anymore, thank goodness. But we give medicine that lowers testosterone that does has the same effect.
As removing,
The testicles.
isn't that something?
Testicles are the source of testosterone.
Yeah.
So we still do it, and it's part of the reason that people still believe this, because if we're lowering testosterone to help men with prostate cancer, then raising testosterone, which is what Huggins said was dangerous, it makes sense that raising it would be bad.
It makes total sense.
Right. Yeah. So that's what Huggins did. And let me tell you, as a medical student learning about castration as a medical treatment, that made an impression on me, certainly.
Yeah.
The guys are all crossing their legs when they heard something like that.
I am too, and I don't even have a penis. It's like, oh.
No, the penis stays.
Oh, right. It's
Just
the balls.
testicles. Just removing the potatoes, but not the sausage. Right. Yeah. So anyway, so that's what that was. I came out of my training, and I started doing sexual medicine. I had guys who were desperate for help with sexual problems. Their wives, their girlfriends were going to leave them. They didn't feel like they were a man. The doctor, wasn't there anything I could do? And it would be another 10 years before Viagra would show up. This 1988. And so I had done this research with lizards as an undergraduate, looking at their sexual behavior, and testosterone was key. And after we'd castrated the lizards, we gave them back testosterone, and I gave it in their brains, which was an amazing...
a cruel thing to do.
Oh, no. Well, I don't know. They did okay.
Well, you should tell the nice people what you did. You froze those fucking animals. You froze them alive.
No, yeah. Well, so it's actually an interesting thing that the way you anesthetize a lizard is you pack it in ice, or it was then, and they, because they can't regulate their own temperature.
So that's sad. And I know I'm getting you off the
They get
topic
comatose.
here.
Yeah.
Okay, so you injected this stuff into their brains, but it wasn't problematic for the lizards.
Well, it restored all their sexual behavior.
Okay.
So when they were happily mating with the females, they didn't look like they really had suffered that much in the long run. So I knew testosterone could work in the lizard.
That makes sense. I'm thinking about that while I'm listening to you. That does make sense. They were happy again.
Yeah, they're happy again.
Okay.
Yeah. So if testosterone could help lizards regain their sexual abilities, because the castrated animals didn't do anything sexual, then maybe it would work in humans. Maybe humans are like lizards. And so I started offering some men, very cautiously, testosterone, because we were worried about prostate. It was going to cause prostate cancer. But these guys, and I would up front with these guys, they'd say, I'll do anything, I'll risk anything. And nobody knew really what the risk was, except it was believed that even a short whiff of extra testosterone could be risky for him. It's funny to think back. It's just, nobody would believe it today.
No, I think a lot of people still believe it today.
No, but listen, but nobody would believe the degree to which we were afraid of this.
Yeah.
So everybody by then knew that, let's say, the biggest risk factor we knew for cancer was smoking and lung cancer.
Yeah.
Okay? Mm-hmm. This was 100 times worse than that in our minds.
Wow.
Like, we really were under the belief that if a guy saw a little bit of extra testosterone, he would develop prostate cancer almost right away.
Wow.
And it would be aggressive prostate cancer.
Oh, my goodness.
So I had a couple of these guys. They said, I told them what these risks were. They said, I'll try it. And they did well, and I kept giving testosterone.
So did well means what exactly?
That they responded sexually, and they responded in these other ways. Like, they felt better. Like the story with testosterone therapy today, I mean, you and I keep talking about this hormone therapy in general, right? Is it makes an enormous difference for the quality of lives of people.
Yeah.
And can affect them in so many different ways, right? Like how they think, how they feel, their mood, their energy level, their motivation, their strength, fatigue, sleep. Yeah, amazing. And sex, of course, but it's so much more than just sex.
So when you say sex, you mean for men, you mean desire, you mean erection, do you mean like better orgasms?
Yeah.
Yeah. So it's a lot. When you say sex, that means a lot of different things about sex.
Yeah.
Yeah.
Yeah. I mean, one of the sexual things is a little story.
Okay.
So when I started doing this, like, it was brand new. And even though I've since learned that when testosterone first became available in the late 1930s and early 1940s, people were trying all sorts of different things with it. And people learned a lot about the sexual and physical consequences of getting your testosterone raised. But all of that had kind of disappeared, all that learning, in the 40, 50, 60 years where it had basically, there'd been a global prohibition against it. So that by the 1980s, when I was in training, we didn't learn anything about the benefits of testosterone. All we knew, and all that was taught in medical school, is that there were these rare cases where people had genetic issues that made them have low testosterone, or they'd lost both testicles and they needed testosterone to be able to function sexually, or they had pituitary tumor. Those were most of the cases, and you put them all together, it's very, very few people. In a city like Boston, where I was working and training, maybe there were a dozen or at most 24 men going to all the different teaching hospitals who were like this. Rare. And in urology, we didn't see this at all. So I was kind of just learning from my patients about what it actually did. And it was astonishing. The data have clearly shown that men who receive testosterone are at no greater risk of getting prostate cancer than men who didn't. Does testosterone cause heart attacks and stroke? Well, I've got an amazing story I want to talk about, which is how out of the blue one day in medicine came the belief that testosterone caused heart attacks and stroke and death. It's not true, but man, we've been struggling with this for about 10 years. It happened suddenly, and it's been so hard to fight back against this. It's just amazing.
Yeah.
You want to hear?
I would love to hear, even though I already know the story, but I would love to hear it again.
So here's the thing. So as research in testosterone was going on, what people noticed was that testosterone, if anything, seemed pretty good for the heart. So that it was known that atherosclerosis, thickening of the arteries, happened in men much more if their testosterone was low than if it was normal. We knew that developing coronary artery disease was more common in people with low levels of testosterone than normal. And there were 2 studies published before 2010 that showed that men who received testosterone compared to men also with low testosterone who didn't receive it actually died at half. Their mortality rate was reduced by half.
Wow. They were on testosterone supplements. Their death rate was reduced by half?
By half.
That's incredible. And this goes for women too, although not that study, right?
The study was in women, but the concept is the same, but less well studied in women. Testosterone levels are a little bit more complicated to interpret in women
Uh-huh.
because they have higher levels often of SHBG.
Ah.
So these were all studies using total testosterone. And one of those mortality studies was in the United States with a veterans population. The other one was from the UK in a diabetic population.
Wow.
Changed by half. Unbelievable.
Yeah.
And then suddenly, in 2013, was published a study in one of the most prominent medical journals, Journal of the American Medical Association. First author is Vegan et al. And it was an observational study, which means it wasn't set up as a study, but they had this big data set and they looked back at it in time. And so they had something on the order of 8,000 men who had undergone coronary catheterization, which is suspected heart disease. And afterwards, some of the men wound up on testosterone and some did not, if they had low levels. And so they looked at three things for both groups. Heart attack, whether they had heart attacks, strokes, or death. And what they reported was that the group that got testosterone had a higher cumulative rate of those bad events, those adverse events. And it made huge headlines. So, the average...
Well, it sounds scary.
It sounds scary.
Yeah.
And so, medical stories are published. There must be 100 published every single day or more. And we hear about very few of them, right, in the newspaper.
Mm-hmm. Yeah.
If you're in your specialty, you may get, some information. But to make it into the news media, it has to have a couple of characteristics. One is it tends to have to be risky, unexpected risk, surprising, right? That's what's newsworthy.
Or scary.
Scary. And especially in a medication that might be frequently used. Like the headline for the newspapers, the media, it's like, oh my God, stop the presses, right? And we've got something going on here. And that's what happened with this. And a couple months later, there was a second paper that suggested maybe there might be higher heart attack risk in men who got testosterone. And so it seemed like back to back, there was a story here. The New York Times wrote an editorial, not an op-ed, but an editorial, which means the editorial staff at the New York Times, who, to my knowledge, doesn't include any physicians or cardiologists, had an editorial that was entitled, Overprescribing Testosterone Dangerously. And so they mixed up a few things. One is they just took this story about heart attacks and strokes and death at face value. And the second is there's been this attitude for a while that too many people are getting testosterone. They don't really need it. It's not a fountain of youth. And that men are just being propagandized into, they're being fooled by drug companies and by unscrupulous doctors into getting testosterone. It was a terrible, terrible thing, but what an impact. And ever since then, we in the testosterone field have to defend and have had to discuss the risks, possible risks of testosterone causing heart attacks, strokes, and death to our patients.
Can you talk about why that study created fear that wasn't valid? Because in your description, it sounds scary.
Yeah. So first of all, there's and nobody ever put together with all the reassuring data from before that a healthy testosterone level was better, or that mortality data that I told you about where the mortality rate was reduced by half. So right away, me and my colleagues knew there was something wrong with that first paper. Why? Because they gave you the numbers for how many people in this group had a heart attack, how many people had a stroke, how many people died, and you knew how many people were in that group. And so that cumulative, what they call absolute rate of events, there's no statistical mumbo jumbo. It's just the number of people who had something bad happen divided by the number of people in that group. That's it. So they have enough information to do it. So I added up those numbers, divided by number of people in that group, and their numbers were wrong.
Isn't that amazing?
Not only were they wrong, they had the story backwards.
Oh my God.
So that the number of people, the absolute rate of events, was twice as high in the group that didn't get testosterone
Oh my
as the group
God.
that got testosterone. So I'm going to tell you the story. This is a little bit how the inside story of medicine and journals, how it works sometimes and also doesn't work. And I've got colleagues around the world, and, we share testosterone stories, we make comments. And so I wasn't the only one. A number of people had done the same thing, and everybody's writing, this is a disgrace, it's terrible.
I remember you told me your colleagues are all emailing you, like, do something, because
somebody has to tell the journal they got the numbers wrong. So I said, okay, I will. And so I called up the editor of JAMA, and amazingly, he took my call. He's a nice guy. And I said, listen, I represent a group of international testosterone experts. Congratulations on your article, and congratulations because it made a big impact. And that's what the journals really care about, right?
Yeah.
To have the regular media pick up on a medical story is huge.
Yeah.
And helps them with their metric of success, which ends up being citations, how many other articles will actually reference them, and how many eyeballs see it. It's still sort of like a clicks world, right? Just like that. And I said, and really my first goal was me and a couple of folks wanted to write an article rebutting this.
Which sometimes journals will do, which is great. And then there's a discussion between authors.
Exactly. So he says, well, we don't really have the room to do that. About once a month, we get a call for something like this. We just can't do it. I'm sorry, but please write a letter to the editor. We take those very seriously. And he's like getting ready to get off the phone. I stop him and I say, listen, can I just show you something in the abstract? I think there's a problem. He says, sure, I've got it up on my computer right now. I say, so the absolute rate of events you have listed is X for this one group and Y for the other group. And actually, you can add up those numbers and divide by the number of people. And those numbers are wrong. And the rate is higher in the group that didn't get testosterone. And there's dead silence on the phone.
He's doing it. He's doing his little...
You can just look at it. It's just wrong.
Oh my God.
And the rate for the testosterone group was about 10%, and the rate for the non-testosterone group was 21%.
Oh my gosh.
It's less than half.
So it's the absolute opposite.
Exactly the opposite.
Of the takeaway.
So I say that to him. I give him a moment I say, maybe you've got a calculator, on your phone, but if you don't, I do, and here's what it comes out to be. And there's dead silence for a moment. He probably did the calculation. And before he can say anything else, I say, your authors made a mistake. Your reviewers missed it. They wrote an editorial that somebody hired to do an editorial. I said, your editorialist missed it.
Oh my God.
And JAMA has an obligation here. This story has gone out around the world.
This changes people's treatment. Exactly. Of course they have an obligation.
And their perception.
For sure.
And he says very slowly to me, he says, I cannot disagree with anything you've said. So for listeners, the ramifications of this finally coming to an end are important because until now we've kind of held back individuals that may have had a heart attack before, people with risk factors like hypertension or diabetes or something else. And I think that that's not true anymore. If somebody's had a heart attack or a stroke, they should know that they're at increased risk of getting another one, whether they go on testosterone or not. But if they go on testosterone, it doesn't mean that testosterone caused it.
I see.
And the data indicate that they're no more likely to have another one because of the testosterone than if they didn't.